Hey everyone, welcome back for another deep dive. We're going to help you make sense of the latest breast cancer screening guidelines.
Yeah, exactly. And make sure you feel comfortable talking about it with your patients.
Right, because it can be confusing sometimes.
Oh, definitely.
Okay, well, let's get right to it.
All right.
Breast cancer. It's the most common cancer in women worldwide.
It's true. And in the U.S., it's the second leading cause of death from cancer for women.
Yeah, that's a lot. So early detection's got to be super important.
Oh, it is. Absolutely. Screening is so key.
Okay, so let's talk about how we figure out a patient's risk because that seems like a big part of this.
Definitely. It's all about their lifetime risk of getting breast cancer.
Okay,
So we use that to put them into one of three groups: average risk, moderate, or high risk.
got it. And that's how we decide when to start screening and how often.
That's right.
So when we say average risk, what does that really mean in terms of like their chances of getting breast cancer?
So average risk means a lifetime risk of less than 15%. And it's really important to explain to patients that that's the risk of being diagnosed, not the risk of dying from it.
That's a good point because that would definitely make people a lot less worried.
Easily.
You said that's like most women, right?
It is, yeah. The vast majority.
Okay, so let's go through those recommendations then, the age-based ones.
Okay.
So what about women under 40?
So under 40, we generally don't recommend routine screening.
Okay,
Breast cancer is less common in that age group. And mammograms, which is what we use for screening,
right.
they just aren't as accurate in younger women because their breast tissue is denser.
Makes sense. So then what about in their 40s?
Yeah, so between 40 and 49, shared decision making is really important.
Okay.
We really need to talk to each patient individually and think about the benefits of finding something early versus, the possible harms of screening.
Yeah, that can be tough, I think.
Yeah.
Can you give us some examples of what those benefits and harms would be?
Yeah. So a benefit would be, if you find it early, maybe the treatment isn't as aggressive and they'll have better outcomes.
Right, like finding a small crack in a bridge early versus letting it get worse.
Exactly.
Now, what about the harms?
So on the other side, there's a chance of a false positive result,
Okay.
which can mean more tests and a lot of anxiety when it might not have even been anything to worry about.
Yeah, those must be hard conversations to have.
They can be. And then there's overdiagnosis, which basically means we find a cancer that would never have actually caused any problems.
So it's not just about finding cancer, it's about finding cancer that needs to be treated.
Exactly. We got to think about whether finding it will actually make a difference.
Okay, so for this age group, 40 to 49, the guidelines recommend screening every other year, right?
Yeah, so the U.S. Preventive Services Task Force, which we call the USPSTF,
Okay.
they recommend what we call biennial screening, so every other year.
And that's changed from what we used to recommend, right?
It has, yeah. So it's good to be up to date on the latest guidelines.
Yeah, because I think a lot of us are used to recommending yearly mammograms.
Yeah.
So how do we explain this to our patients who might be expecting that?
I think being open with them and explaining that the research shows that doing it every other year is a good balance.
Okay.
It still catches things early, but lowers the chances of those false positives and overdiagnosis.
Got it. And then once a woman is 50, that's when things change again.
Yes. So from 50 to 74, the USPSTF strongly recommends mammograms.
Okay.
And either every year or every other year is fine.
So we're back to shared decision-making for that.
Exactly. You
Yeah.
talk it over with your patient and see what works best for them.
Okay. And what about women 75 and older?
So for that age group, the guidelines suggest offering screening if their life expectancy is at least 10 years.
Got it.
But it's case-by-case thing, looking at their overall health.
Okay. So we've been talking about mammograms. That's still the main test for all these women, right?
Yes, it's what we call the gold standard for breast cancer screening. It's the only imaging technique that's been proven to actually reduce the number of deaths from breast cancer.
And there are different types of mammograms, right?
Yeah, there are.
There's digital and 3D mammography, which I hear more and more about. Can you explain the difference and what we should be recommending?
Sure. So with 3D mammography, it's also called digital breast tomosynthesis, but basically it takes a lot of pictures from different angles.
Okay.
So you end up with a much more detailed image than with regular digital mammography.
So it's like a flip book of the breast, kind of.
Exactly. And that's really helpful for women with dense breasts because it can be harder to see things on a regular mammogram.
Makes sense. And what about clinical breast exams and breast self-exams? Are those still part of the recommendations?
They're great for helping women get to know their breasts,
Okay.
but on their own, they're not really effective at reducing breast cancer deaths.
So we don't need to tell our patients to do self-exams every month anymore.
No, we're moving away from that.
Oh,
It's more about encouraging them to just be aware of what's normal for them and to tell us about any changes.
So being proactive and knowing their own bodies.
Yeah.
All right, so we've covered average risk pretty thoroughly. Now, what about moderate and high-risk women? What are the differences there?
So for moderate risk, which means a lifetime risk between 15 and 20%, it's usually the same as for average risk.
Okay.
But when we get to high risk, so over 20%, that's when we start to do things differently.
And what's different for those women?
We add MRI to their screening, so they get an MRI in addition to their mammogram.
Okay, why do we do that?
MRI is just way more sensitive than mammography, particularly for cancers that might be hidden in dense breast tissue.
That makes sense. And are there downsides to using MRI?
Well, it's more expensive and there's a higher chance of a false positive.
Right. So again, we have to weigh the benefits and the risks.
Exactly.
You mentioned BRCA mutations as a reason someone might be high risk.
Right.
What else puts someone in that category?
So besides BRCA, there's a history of chest radiation before age 30, certain breast conditions, or if we calculate their lifetime risk to be over 20% based on other factors.
So it's like a puzzle, putting all the pieces together to get their overall risk.
That's a good way to put it.
Before we move on, are there any other important things for us as general practitioners to keep in mind?
Yeah, there are a few more points worth mentioning.
Okay, let's hear them.
So dense breast tissue, we've talked about it, but it's super important
Right.
because it can make cancers harder to see on a mammogram.
And why is it especially important for us to know about this?
Because now mammogram reports actually have to include information about the patient's breast density.
Oh, wow, that's great. So we have it right there in the report.
Exactly. And then we can talk to our patients about whether they might need additional screening, like an MRI or ultrasound.
So for those women with dense breasts, we'd be thinking about more than just the mammogram.
Exactly. It's all about tailoring it to the individual patient.
Now, what about women with breast implants? Does that affect their screening?
We still recommend mammograms for them, but it's to look at the breast tissue that's still there.
Okay, so the implants don't block the view completely?
They can make it a bit harder to see, but radiologists have special techniques to work around that.
And what about women who've had breast reconstruction after a mastectomy?
If there's no breast tissue left, then there's not much point in doing a mammogram.
Makes sense. What about if they've had biopsies before for benign conditions? Does that change anything?
Not really. If there are no other risk factors, they're still average risk, and we just follow the usual guidelines.
Okay, so a past biopsy doesn't automatically make them high risk.
Right.
All right, so we've talked about dense breast tissue, implants, reconstruction, and biopsies. What else is on your list?
Okay, let's talk about hormone therapy.
Okay, how does that tie into all of this?
It can increase breast density, which, as we said, can make mammograms less accurate.
Right, so another thing to consider when we're looking at the mammogram.
Exactly. And while it can slightly raise the risk of breast cancer, the guidelines are still basically the same.
Got it. So just another thing to bring up in those conversations with our patients.
Right.
What about women who don't have a long life expectancy because of other health problems? Do we still screen them?
That's a tough one. For women with a life expectancy of less than 10 years, it's likely that screening won't really benefit them much, especially if their health issues would make treatment harder.
So in those cases, it's more about having those conversations with the patient and their family and figuring out what's best for their quality of life.
Exactly. It's about focusing on what matters most to them.
And those conversations should be really compassionate and understanding of each patient's situation.
Absolutely. It's about more than just following the guidelines. It's about individualizing care.
I agree. Okay, one last thing before we move on. I wanted to touch on the COVID vaccine and mammograms because that's been a big topic.
Oh, yeah. Definitely something we should talk about.
So what do we need to know about that?
So the COVID vaccine, especially the mRNA ones, can sometimes cause swelling in the lymph nodes under the arm.
Yeah, and I remember people being worried about that showing up on mammograms.
Yeah, there was a concern about that. But the good news is that swelling usually goes away on its own, and radiologists know to look out for it.
So women shouldn't worry about the vaccine affecting their mammogram results.
Exactly. Keep up with your mammograms as recommended by your doctor, and if you have any concerns about swelling, just talk to them.
Okay, good to know. Well, I think we've done a great job of breaking down these guidelines and all the things we need to consider as general practitioners.
I think so too. We've laid a good foundation.
Exactly. And in the next part, we'll look more closely at the benefits and harms of screening in more detail. So stay tuned for that.
Sounds good.
Okay, so we've got a good handle on the guidelines now, but let's dig a little deeper into the actual benefits and harms of screening.
Yeah, good idea, because that's what it really comes down to, right?
Exactly.
Yeah.
And for you as general practitioners, that's what you're talking to your patients about.
For sure. We got to understand both sides of the story.
Okay, so let's start with the benefits. We know the main goal is to prevent women from dying from breast cancer.
Yeah.
But what does the research actually say about whether screening really works for that?
Well, a lot of studies, including some really big ones, have shown over and over that mammograms do lower the risk of dying from breast cancer.
That's good to hear. Are there numbers on how much it lowers the risk?
Yeah, there are. So a review in 2015 looked at a bunch of studies with over 600,000 women and found that mammography screening probably reduced the risk of dying from breast cancer by about 20%.
Wow, 20%, that's huge.
It is.
Are there things that affect how much benefit a woman gets from screening?
Definitely age is a big one. The benefit is smaller for younger women just because they're less likely to get breast cancer in the first place.
That makes sense. So the older they get, the more important screening becomes.
Exactly.
Okay, so we've talked about saving lives, which is obviously the biggest benefit.
Right.
But now let's talk about the other side. What are some of the harms that we need to think about and discuss with our patients?
One that comes up a lot is overdiagnosis, which we mentioned earlier.
Overdiagnosis, right? Can you remind me what that means exactly?
It's basically when we find a cancer through screening that never would have caused any problems for the woman.
So it's a cancer that wouldn't have grown or spread or caused any symptoms?
Right. It's like finding something that was never going to be an issue.
And that can happen with breast cancer because some of them grow really slowly or might not even grow at all.
Exactly. And that's a problem because it means we might be treating something that didn't need to be treated.
Right. And treatment has side effects and can be expensive and
Yep.
cause anxiety.
Well, true. That's why we have to talk to patients about this possibility and help them weigh the pros and cons.
Yeah, transparency is so important. What about false positives? I hear about those a lot.
Yeah, false positives are a big concern.
Okay.
It's when the mammogram looks like there's something suspicious, but it turns out to be nothing.
So basically a false alarm.
Yeah, but it can still be really stressful for the patient.
Oh, for sure. They have to go through more tests and biopsies and wait for results, all for nothing.
Exactly. And that can be really hard emotionally, and it might even make them not trust the screening process anymore.
That makes sense. So how common are false positives?
In the US, it's thought that about 10% of screening mammograms lead to a false positive.
Okay.
And if you think about a woman getting mammograms every year for 10 years, there's a 50% chance she'll have at least one false positive during that time.
Wow, 50%. That's a lot higher than I would have thought.
Yeah, it is. It really shows why it's so important to talk about this up front and be realistic about what might happen.
And of course, there are also false negatives.
Right. When the mammogram looks normal, but there actually is a cancer.
Okay.
It's not as common as a false positive, but it can happen.
And obviously, that's a big problem because it could delay treatment.
It could. That's why it's so important for women to know that even if their mammogram is normal, they should still pay attention to their breasts and tell their doctor about any changes.
So it's not just about the mammogram. It's about being aware of your own body. Okay, so we've covered overdiagnosis, false positives, and false negatives. What else do we need to consider?
There are a couple more, but we don't always talk about them as much.
Okay, what are they?
One is radiation exposure. Mammograms use a very low dose of radiation, but it's still something to think about,
Okay.
especially for women who get screened a lot.
Right, like those high-risk women we were talking about.
Exactly. And then the other one is discomfort.
Okay.
Some women find mammograms to be uncomfortable or even painful because of the breast compression.
Yeah, I've heard that from patients.
It's important to acknowledge that and let them know it's temporary. There are also ways to make it more comfortable, like scheduling it for a certain time in their cycle or taking a pain reliever beforehand.
Those are good tips. So there's a lot to think about when it comes to screening. It's not as simple as it seems.
It's really not. It's complicated, and there's no one right answer for everyone.
And that's why shared decision-making is so crucial. It's not just about giving patients the facts. It's about helping them figure out what those facts mean for them
I
personally.
got it. We want them to make choices that they feel good about.
So how can we as general practitioners have these conversations in a way that really empowers our patients?
Well, first, we need to be having these conversations in the first place. We can't just assume that everyone wants to be screened or that they agree with the guidelines.
So we need to start the conversation, not wait for them to bring it up.
Yes. And when we do talk to them, it needs to be focused on them and their individual needs.
What does that look like in practice?
It's about really listening to them, understanding their situation, what they're worried about, what's important to them.
Okay.
We should ask open-ended questions and let them share their thoughts and feelings.
So it's not about us telling them what to do. It's about working together to make a decision.
Exactly. It's a partnership.
I like that.
Right.
And one way to help with that is to use decision aids.
Yes. Decision aids are great.
What are those
Yeah.
exactly?
They're basically tools that help patients understand the information about screening and make a decision that's right for them. They can be pamphlets, videos, or even websites.
So it's like extra information to help them process everything.
Exactly. And studies have shown that they actually help patients feel more knowledgeable and confident about their choices.
That's great to hear. It sounds like they could be really helpful for us as general practitioners.
Oh, they definitely can. They can make those shared decision-making conversations much easier and help us provide better care.
I'm sold. Well, listeners, I hope this discussion about the benefits and harms of breast cancer screening has been useful.
Me too.
As you can see, it's a complex issue with no easy answers.
For sure.
But by using shared decision-making, considering decision aids, and talking openly with our patients, we can help them make choices that they feel good about. Now, before we wrap up this episode, we have a few more things to cover. Okay, so we're back and ready for the last part of our deep dive into breast cancer screening guidelines.
Yeah, we've covered a lot, but there are still a few practical points I think would be helpful to touch on.
All right, what else do we need to talk about?
Let's think about women who are taking hormone therapy, for menopause symptoms or other reasons.
Yeah, how does that affect their risk and the screening recommendations?
Well, one thing to remember is that hormone therapy, or HT, can make breast tissue denser.
Right, which we've already talked about, can make mammograms harder to read.
Exactly. And HT can slightly increase the risk of breast cancer too, but the screening guidelines are basically the same, whether they're taking HT or not.
Okay, so it's not a huge change in terms of when we screen or how often, but it's something to keep in mind when we're thinking about their individual risk.
Right, exactly.
Now, what about women who might not have a long life expectancy, because of other health problems?
Yeah, that's a tough one, but important to think about.
Do we still recommend screening for them?
Well, if their life expectancy is less than 10 years, it's likely that screening won't really help them that much, especially if those health problems would make treatment difficult.
Right. So in those cases, it's even more important to talk with the patient and their family about what's best for them and what their goals are.
Absolutely. It's about focusing on their quality of life and making sure any decisions align with that.
And those goals might be different for someone who isn't expected to live as long compared to someone who's otherwise healthy.
Exactly.
Okay, one last thing before we wrap things up. I wanted to bring up the COVID vaccine and its potential impact on mammograms.
Oh, yeah, good point.
What's the main thing for general practitioners to know about that?
So the COVID vaccine, especially the mRNA ones, can sometimes cause some swelling in the lymph nodes under the arm, and that can show up on a mammogram.
Yeah, and I remember there was concern that it could be mistaken for something more serious.
There was. But the good news is that the swelling usually goes away on its own. And radiologists are aware of this now, so they take it into account when they're looking at the mammograms.
So it shouldn't be a reason for women to put off their mammograms.
Exactly. The important thing is to stay up to date with your mammograms as your doctor recommends. And if you're worried about any swelling, just talk to your doctor about it.
Sounds good. Well, I feel like we've really covered a lot of ground today. From the global impact of breast cancer to the newest screening guidelines, from individual risk factors to those tricky conversations about the benefits and harms of screening.
It has been a thorough deep dive for sure.
And I hope all of you listening, especially our general practitioner colleagues, feel more prepared to talk to your patients about all of this and help them make the best decisions for themselves.
That's what we were hoping for.
I want to leave everyone with one final thought. Breast cancer screening recommendations are constantly evolving as we learn more. So it's really important to stay up to date, be open to new evidence, and always focus on what's best for each individual patient.
I completely agree. The goal is to catch breast cancer early when it's most treatable, but also to minimize any potential harm from a screening. It's a balancing act, but working together with our patients, we can do it.
Well said. Well, thank you so much for joining me for this deep dive. It's always great to learn from your expertise.
My pleasure. And to all our listeners, thanks for tuning in. We'll be back soon with another deep dive into the world of health and medicine.